Good afternoon, everyone. Today we'll discuss about hand orthosis. ऑर्थोसिस या प्रोस्थेसिस के बारे में बेसिक आइडिया है आप लोगों को या नहीं है? ऑर्थोसिस और प्रोस्थेसिस में क्या डिफरेंस है? नहीं? See, orthosis is for support, and prosthesis is the replacement of the lost body limb or body part. Okay, so that's the basic difference. So today we are discussing only about hand orthosis. So what is the definition of orthosis? If someone is asking you, that it is a device that is applied externally to the body to support or improve the function of that particular body segments. So today we will be talking only about the upper limb section. So here in this picture you can see that there are many. On the leftmost column is the deformities, then the orthosis, and that orthosis is correcting the deformity. Basic principle and indication for prescription of orthosis there are three basic principles. First one is for the protection of that particular limb or the particular joint which is the orthosis is supporting by providing compressing forces and traction to the joint or limb. Second is the correction of the joint contracture or subluxation of the joint or tendons from the joint, and third is the assistant of the function by compensating for the deformity, muscle weakness and increased muscle tone, as we can see in spasticity. And the basic classification of orthosis, that it can be a non-articular orthosis which is just the resting hand orthosis, or a static one which is made in a particular position. Serial static, like in which we have to serially change the angle of the orthosis according to the deformity for the correction of the same. Then the static motion blocking, in which there is block on the particular either in flexion or extension. Then static progressive, as we can see in knuckle binder orthosis. Then dynamic, which is we can again see in tenodesis orthosis or tenodesis splint. Then dynamic motion blocking, it is same as the tenodesis splint. And then the continuous passive motion orthosis, as we give in the patients who have undergone the total knee replacement or total hip replacement surgeries and who are coming to us in OPD for the maintenance or for the improvement in the range of motion of the knee joint or hip joint. And last one is the adaptive or functional splint, which is given to prevent the further deterioration of the deformity in patients who are paraplegic, quadriplegic. Okay. First we'll discuss about the non-articular one. It supports a particular body part without crossing any joint. As we can see in this picture, this orthosis is neither crossing the shoulder nor the elbow joint. It protects the bone or the particular bony part. This kind of orthosis is given for the patients who have suffered humeral fracture or proximal radius fracture. Come in. Then the static one. This is the functional orthosis. It provides the static support to hold a joint or joint stationary. The one which is in the picture is the volar wrist splint. The complications associated with the use of static orthosis is due to the continuous pressure on bony prominences or weak skin or thinned out skin. It will lead to the skin breakdown. And if the patient is keeping his hand in a particular position, then eventually he will develop the contracture or infection due to excessive sweating or to the environmental conditions. Then the serial static, it is static but it is periodically changed to change the angle at which splint is positioned. As in this position, this patient may have suffered from the contracture at the elbow joint. The one you can see this rod, this is the turnbuckle mechanism. So gradually each day patient will turn the buckle and open up this rod to further reduce the contracture and to straighten the elbow. Then the static motion blocking, it prevents motion in one direction but permits in the other one. The picture here we are seeing is the swan neck splint. It is preventing the extension but helping in the flexion. Then the static progressive, it uses as a static line of pull that is tightened periodically to increase the tissue length. And the principle of this orthosis is the joint is placed in a position of stretch to regain the motion. In it we have a total end range time. Come in. Here we have the total end range time, that is the length of the time joint is held at the end of its range. The longer this total end range time, the more quickly a contracture resolves. Then there is dynamic splint. It provides the elastic force to regain the motion. The elastic force is either provided by the rubber bands. Here in this case, this is the Kaplan splint. Here the elastic force is provided by the spring kind of mechanism, which we can see at the PIP joint. This is the mechanism. These two rings are made up of thermoplast, which is the material used for preparation of the orthosis. And this ring is the dynamic spring wire finger coil assist, which helps in maintenance of the extension motion. Okay. The basic guidelines for dynamic splinting, it was given by Hepburn in 1987. The three basic guidelines. First, the stretch should not be perceived as a stretching force until at least 1 hour has passed. Okay, and then the client should remain comfortable with the orthosis for up to 12 hours, because sometimes the patient has to wear orthosis for the 24 hours. After removal, the client should feel no more than a stiffness or mild ache, and we have to always ask the patient to look for any kind of redness, skin breakdown when he has removed the orthosis. If the redness or any skin breakdown or stiffness or excessive pain is there, that means the orthosis is not made properly and we have to redesign it. The dynamic motion blocking one, it allows the motion in a certain range and it blocks in the other. It utilizes the passive elastic lines of pull in a desired direction and permits the active motion in the opposite direction. It utilizes the passive elastic line of pull in a desired direction but permits active motion in the opposite direction. So here this elastic cord is there, which is permitting the flexion, and the patient himself can do the extension and flexion movement and maintain the strength as well as the range of motion of the particular joint. The name of this kind of splint is Kleinert post-operative splint, which is then generally given after the tendon transfer surgeries or tendon repair surgeries. Dynamic traction splint, it again offers the traction to a joint while allowing controlled motion in a desired range of motion, and the name of this splint is Schenck splint, and it is given in patients who have suffered the intra-articular fractures to prevent the ankylosis of the joint or inappropriate fusion of the bones. Then the continuous passive motion orthosis, electrically powered devices that mechanically move joints through a desired range of motion. Because once the patient has undergone the total knee replacement or total hip replacement, the patient will not be able to regain the normal range of motion as it is in the knee or his hip joint. Can any one of you tell me the normal range of motion of the knee joint and hip joint? What is the normal range of motion of hip? What is the arc? बताइए. किसी को तो पता होगा. फुल एक्सटेंशन कितना होता है नी का? 15 डिग्रीज कितना होता है? टोटल आर्क पूछ रही हूँ मैं, रेंज ऑफ मोशन नी का कितना है? गैस भी नहीं कर सकते हो? 175 से थोड़ा सा कम है. 0 to 135 है टोटल. ओके. और हिप का? हिप का एक्सटेंशन, फ्लेक्शन, एबडक्शन, एडक्शन? नॉर्मल चीज़ें, बेसिक चीज़ें तो आप पढ़ के रखो. पता है किसी को तो बताइए. Basically, these continuous passive motion orthoses, they are electrically powered, and that's the reason it is passive motion. Patient is not applying any kind of force from himself, and it's desired to keep the joint supple, maintain ligamentous, articular and tendinous structure and flexibility. Then there is adaptive functional splint. It promotes the functional use of the upper limb with impairment due to weakness, paralysis or loss of body part. Then the hybrid one, it has features of both static and dynamic orthosis. It crosses the multiple joint, as you can see in this picture. It is crossing the wrist joint, the MCP joint, the BIP joint and DIP joint. It limits or stop motion at one joint and allows augment motion of the other joint. The goals of the basic orthosis is to substitute for weak or absent muscles. Okay, then protect disease or damaged segments by limiting load or motion. Prevention of the deformity due to weakness or nerve injury. Correction of contracture in chronically paralyzed or immobilized patients. and attachment of other assistive devices, unless like the universal cuff, which is given in stroke patients or spinal cord injury patients who have lost their hand grips. The basic biomechanical principles of the orthosis is, first one is the 3-point control concept, then the tissue tolerance to compression and the shear forces applied by the orthosis, biomechanics of the liver and forces, as the physics always helps in these things, and the selection of material from which we will be making the orthosis. According to the environmental conditions, we have to choose the different materials according to the disease and according to the condition of the patient. Then whether we should prescribe a static or dynamic control. First, we'll discuss about the 3-point control principle. In it, a strong force is applied at a point and counter force is applied proximal and distal to the joint. So in this picture you can see this force is at the joint. Let's suppose this force is at the elbow joint, and these two are the distal forces. One is at the head of the humerus and other one is at the radial end. The precise point of application and magnitude of applied is critical. That's why we have to always consider the appropriate points of the application of the forces. Tissue tolerance to compressive and the shear forces. Basically, in hands we have many small bones, which leads to the development of 30 pressure sensitive bony prominences at the wrist, hand and fingers. So the highest pressure which can be tolerated till up to the 2 to 4 hours continuously is around 100 to 300 millimeter of mercury, and lower pressure is 20 to 50 mm of mercury is tolerated till up to the 12 hours. Why it is important? Because we have to decide how much force we have to apply to correct the deformities, and distribution of pressure over larger area is better tolerated, which is done by application of a foam layer or Ethaflex layer or soft inner lining to the orthosis. Then the biomechanics of the liver and forces. By increasing the liver distance, less pressure can be generated, same force across the joint, or angle of pull is perpendicular to the joint. Here if we see the example of the elbow joint, so the angle of pull is the movement arm, which is perpendicular to the muscle force which is applied by the biceps muscle. Okay. Then the biomechanical principle of the materials which we are selecting for the preparation of the orthosis. It should be a flexible, it should have strength, and it should be a durable material, so it will be available to the patient for a longer period of time and less number of changes has to be done. So there are basically 4 types of materials which are used. First one is the low temperature thermoplastic. As you can see in this picture, it is more wide and it's soft and it can be easily malleable and easily reshaped. Okay, and then the other one, which the small granules you can see, it is the polyethylene. It is the high temperature thermoplastic, which is for longer term and which has the tolerance level for the high stresses. Then the third one is the carbon fiber device, which is the recent new addition to the list of the materials. It is very strong as well as it is very light, but again the repeated changes, reformation of the orthosis is difficult with carbon device. Once you have made it with the carbon device, then you have to again reframe it. You can't use the same one. And last one is the foam material, which is important to improve the tissue tolerance in high pressure areas to prevent the skin breakdowns. Apart from it, various materials such as wood, iron rods, iron splints or steels, these springs, all these kind of materials are also used in the orthosis. The common hand orthoses are the finger and thumb orthosis, hand and finger orthosis, wrist hand finger orthosis. So first we will discuss about the finger and thumb orthosis to treat the fractures, to maintain the proper positioning for the correct fusion of the bones, collateral ligament sprains and burns of the digits. It may be a partial or complete. That means whether it will be covering the whole joint or it's just covering the half of the joint. It can be static position at the interphalangeal joint, either in extension or flexion, and it can be decided according to the movement which is required. The few examples are finger ring orthosis, which is used in the sonic deformity or Botnius deformities as seen in the rheumatoid arthritis patient. First one is the finger stabilizer or static finger orthosis. It is used to stabilize the interphalangeal joints. These are the distal interphalangeal joint, proximal interphalangeal joint, or the both joint in a single splint, which is known as gutter splint, or static finger splint, stack splint or axial finger splint. It is used to restrict the motion of the PIP or the DIP joint. As you can see in this picture is showing a splint which is restricting both interphalangeal joint and the proximal and distal one. Generally, the interphalangeal joints maintained in full extension to keep the collateral ligaments stretched and to prevent the interphalangeal flex contracture unless condition dictates otherwise. The other example of finger and thumb orthosis is the ring orthosis. It is the swan neck orthosis or Botnia orthosis. It prevents the first one is for the Botnia's and Botnia's deformity. It is the hyperextension of the PIP joint via 3-point pressure system, but allows pull at the interphalangeal joint. And the Botnia's one, it immobilizes the proximal interphalangeal joint in extension to prevent the flexion through a 3-point pressure system. Okay. Then the finger stabilization orthosis, in it the interphalangeal extension mobilization orthosis, the passive extension of the PIP joint. Examples are dynamic interphalangeal extension splints, reverse knuckle bender splints, Kapner splints, safety pin splints, spring coil splints or axial splints. In this splint, the hand is in the extension. This splint is preventing excessive flexion of the MCP joint. It is keeping the DIP and PIP in extension, and MCP is also in extension. But in this splint, the patient, since it's the finger mobilization orthosis, the patient will be able to move his fingers. He will be able to make the grasp, but again the fingers will be bounced back into the extension. Then the interphalangeal flexion immobilization orthosis. It is passively flexes the PIP joint. It is used for finger interphalangeal extension contracture. Passively flex PIP joint and used is for finger interphalangeal extension contracture. Examples: dynamic interphalangeal flexion splints, finger knuckle bender splint, or fingernail hook orthosis or buddy splint. It is used in the claw hand deformity. Then the hand finger orthosis. The goal is to gain the control over MCP joints of the finger and thumb. Traditionally, it was made of metal wrapped around the medial and lateral side of the hand because it has to cover the metacarpophalangeal joints. It should preserve the arc of the hand to maintain the proper functioning of the hand, and can also incorporate MCP joint extension block. Mainly, it is given in the median nerve injuries. What kind of deformity will median nerve injuries cause? बताइए कौन सी डिफॉर्मिटी का नाम बताओ? CTS होता है, और CTS इज अ कंडीशन. डिफॉर्मिटी क्या होगी? Claw hand. Okay. If median and ulnar both are included, then the complete claw hand is there. Then there is the ulnar claw hand and then the median claw hand. Okay. Then the other one is the basic opponent's orthosis. The thumb orthosis that consists of a dorsal and a palmar bar, as you can see in this picture, encircling the mid palm, which is a thumb abduction bar projecting from the palmar bar. This is the palmar bar. Okay. Example is the short opponent splint. It is also known as C-bar splint, cone splint, or static thumb splint. Other one is the thumb spiker splint. It is generally prescribed in inflammatory conditions affecting the thumb, such as rheumatoid arthritis, decurving tenosynovitis, osteoarthritis, etc. Okay. Can anyone tell me what tendons are involved in decurving tenosynovitis? What is decurving tenosynovitis? Nobody? होता क्या भी पता नहीं है. सुना ही नहीं क्या वर्ड कभी? कंडीशंस वगैरह के बारे में. इट्स बेसिकली फॉर द एब्डक्टर पॉलिसिस लॉन्गस एंड एक्सटेंसर पॉलिसिस ब्रेविस का इसमें इन्वॉल्वमेंट होता है. स्नफ बॉक्स यू गाइज नो, तो वहीं पे होता है ये. सो द बेसिकली पेशेंट विल कंप्लेन अबाउट, एज यू कैन सी इन दिस पिक्चर, this is the site of the pain, and we have to keep the thumb in this position to prevent the repetitive trauma to the tendons, and meanwhile we will prescribe him medicines so that the inflammatory condition will resolve, edema will resolve, and patient will be normal again. Okay. Then the dynamic hand-finger orthosis for extension and flexion contracture across the metacarpophalangeal joints. It's known as the knuckle bander splints because knuckles, you understand, these are the knuckles and this splint is bending the knuckles. That's why its name is knuckle bander splint. As the flexion contracture improves, position of outrigger, that is this cord, and sometimes we also have a spring here which can be adjusted to accommodate this change in the range of motion. Then the ulnar deviation correction splint. Ulnar deviation is mainly seen in the rheumatoid arthritis patients. This orthosis is used to limit the ulnar deviation of the metacarpophalangeal joint with unrestricted, if possible, MCP flexion or extension in the arthritis patients. So the thing is, the ulnar deviation is happening because of the radial deviation of the wrist. So you always have to see the wrist also and the metacarpophalangeal joints also. Okay, and accordingly, along with the range of motion exercises, mobilization exercises, we can prescribe these orthoses. Then the metacarpophalangeal mobilization orthosis. Here you can see these are the springs, these are the rubber cords. Okay, it is used for extend the MCP joint in MCP flexion contractures in patient who have suffered burns, a patient who has undergone open reduction internal fixation of the metacarpal fractures, patients with weak finger extensions such as in cases seen with the radial nerve lesions or brachial plexus lesions. The example of such orthosis is reverse MCP knuckle bander, which is seen in this picture. Then the dynamic metacarpophalangeal extension splint with dorsal outer trigger or MCP extension assist with radial nerve splints. Then the MCP flexion mobilization orthosis. It is used to flex the MCP joint in MCP collateral ligament contractures, extensor tendon shortening. Okay, then the median or ulnar lesion in claw hand. If the patient has undergone capsulotomy of the wrist joint of the MCP joint or internal fixation of the joint, then the MCP knuckle bender is the example of such orthosis. Dynamic MCP flexion splint with volar outrigger and fingernail hooks. So here we can see this spring. Apart from this spring, there can be hooks attached to the nails of the patient which is performing the same function. Then the wrist hand finger orthosis. It is the volar wrist hand stabilizer or wrist cock-up splint, extending from the distal 2/3 inch of the forearm to about the first quarter proximal of the distal palmar crease to allow full metacarpophalangeal flexions while maintaining the functional position of the wrist and hand. The functional position of the wrist and hand is achieved when the wrist is in 5 to 10 degrees of extension is fixed. It is mainly used in the carpal tunnel syndrome. Then the volar wrist hand stabilizer or wrist cock-up splint uses are resting wrist and hand in acute arthritis conditions, wrist sprains or contusions, flexure extensor tendinitis, CTS, post-surgical wrist extensor tendon repair, wrist fusion, or in patient who has undergone wrist skin grafting, contracture prevention and reduce pain, spasticity or prevent ulnar and radiant deviation. Then the dorsal hand stabilizers. This orthosis is used to provide the same function as the volar wrist hand orthosis as well as greater stabilizer because it is rigid dorsal hand section. It's more difficult to fabricate and fit other than the volar wrist hand orthosis. Then the tenodesis prehension orthosis, also known as the finger hinge orthosis. It is a dynamic orthosis. It incorporates an active wrist extension movement. You guys understand tenodesis grasp. Tenodesis grasp is basically because of the attachment of the flexion or extension tendons in the hand. So if the patient is suppose patient is paralyzed, then we'll ask if we will extend his wrist. So this grip is coming. This is a 3-jaw chuck movement. When it's flexing, again the fingers are going away, and when it's extending, this grip is coming. So we'll utilize this thing only in this orthosis. It is a dynamic kind of orthosis. If in the automatically the wrist will go in extension and patient can bring it to the flexion, in which the extensors are weak and and flexors are there. It is generally used in the C6 level quadriplegics where some wrist extension strength is maintained while little or no longer flexor strength is there. Okay. And then the wrist hand finger orthosis or Rehabilitation Institute of Chicago tenodesis splint. It is made up of low temperature thermoplastic It has three different separate parts. First one is the wrist leg, then the short opponents and the dorsal plate over index and middle finger. Here you can see the finger cuff, which is here it is written as index and middle finger. Then the thumb spiker, dynamic elastic band assist, and the forearm cuff. It uses a cord. This is the cord or string running from the wrist piece across the palm and up between the index and the ring finger. The string is lax when the wrist is flexed and tightens when the wrist is extending, bringing the fingers close to the immobilized thumb and accomplishing the three-jaw chuck movement. The three-jaw chuck prehension or movement is required to hold or grasp any object. Then the other specialized orthosis are the universal cuff orthosis, which is simply it is a band which is attached to the palm surface of the patient, and there is a gap in that band where he can attach the spoon or any kind of device he wants. He can, if he is a mechanic, he can use the screwdriver by attaching in this universal cuff. Okay, then the prosthetic hook. If hand is not usable due to contracture, it can be applied to the palmar surface of the hand, and paralyzed hand can be used at the helper hand for opening this hook. The tendinitis or synovitis and enthesopathy splints are decurvent tenosynovitis given to immobilize the affected structure, or lateral epicondylitis or tennis elbow orthosis, which is given to change the forearm lever against which the wrist extensors pull. Then the trigger finger, it is due to trauma in the flexure tendon sheath which stops the movement of the PIP joint. The goal of the splint is to hold the repetitive motion temporarily. The splint should cover proximal phalanx and MCP joint to avoid the fixation of the flexure tendon sheath to the tendon. Then the sprains, momentarily or subluxation with spontaneous reduction, or pain, swelling or decreased function. The goal of these splint is to functional use and healing. The finger extension speed as seen in this picture is given, which holds the PIP joint in extension because of this force and these two forces, and flexes the DIP joint. The DIP joint is free for the movement. Then the other sprain related orthosis are ulnar collateral ligament injury at the elbow, or the wrist sprains or sprain of the elbow. The different kind of neoprene sleeves can be prescribed for such cases. Then the rheumatoid arthritis. In the common deformities which are seen in rheumatoid arthritis are subluxation or ulnar deviation of the metacarpophalangeal joints, subluxation or radial deviation of the wrist, swan neck deformity or Botnier deformity. The splints which are given are given according to the name correction of the deformity only, that is the ulnar deviation splints, wrist splint or swan neck, and Botnier splint. In osteoarthritis, commonly involves the carpometacarpal joint of the thumb. So again, thumb spiker splint is given. In nerve injuries, distal median nerve injury, splint has a spring coil design holding MCP joint in slight flexion with permitting MCP extension, and thumb is placed in palmar abduction. This is the same, we have seen this earlier. Then in the radial nerve injury, forearm based splint with the outrigger. Outrigger is basically this mechanism that holds wrist, thumb and finger extension and allows for extension of the digits. Then the proximal ulnar nerve injury, mainly in ulnar nerve injury we see the benediction hands. The splint holds the metacarpophalangeal joint of fourth and fifth finger in slight flexion with spring coil to figure of the 8th splint design. The figure of 8th splint design is the it's not visible here, this one. Okay, then here we have a metacarpal bar, then the dynamic spring or knuckle bender assist which is helping in the flexion of the MCP joint, and this is the lumbrical bars. Then the median nerve injury in the carpal tunnel syndrome, it is a cock-up splint in which the wrist is immobilized in 0 to 5 degree of extension and should be worn for 4 to 6 weeks with gradual weaning. Basically this splint is worn at the night time only. Okay, the patient should not wear it while working in the daytime. Then the deformities related to brain injury or stroke, it to prevent the deformity and help the adjust the muscle tone according to the involvement of the limb. Resting and positioning orthotic device to prevent distal edema or joint subluxation and contracture formation in the completely paralyzed persons. The examples of these splints are wrist in slight extension, MCP joint in slight flexion, and interphalangeal joint in full extension, as you can see in this picture. And thumb is between the palmar and the radial abduction. And in patients with proximal upper limb weakness, mobile arm support can also be given. In spinal cord injury, patient we give to enhance the function and help the position of the joint. It depends on the level of the injury and extent of the neurological compromises. If the patient has suffered injury in C1 and C3 level, then the goal is solely to prevent the contracture and hold wrist and digits in a position of the function, and resting hand splint can be prescribed in this condition. In C4 level injury, the goal is to use available shoulder strength to provide the mobile arm support. So here in this picture, this lever is providing the movement of the arm, and this is the universal cuff. With help of this and this, the patient can feed himself. And C5 level injury, statistically position wrist in extension with the ratchet type wrist orthotic device to hold device and use shoulder musculature as for function. In C6 tetraplegic patient, it can enhance the finger flexion using tenodesis flexion. It affects from the wrist extension. The same, it's an example of tenodesis splint which can be given to the patients who have suffered at the C6 level tetraplegia. Post-surgical or post-injury orthosis to help regain motion in stiff joints. This is an example of the upper arm or elbow orthosis. Then same splint can be given for the Colles and stiffness after crush injuries to the hand. The main function of these orthoses is to simply support the affected part. If the patient has undergone flexion tendon repair, then we can give the Clenard and Duran orthosis and extension tendon repair, or in mallet finger surgery, that is a stack splint. Here you can see in picture, this is the stack splint. It is a static splint holding the DIP joint in full extension. Then the orthosis for burn, to comfort the patient, maintain the joint in flexed or abducted position, may lead to loss of the functional range of motion. So the goal of splinting here is to prevent the contracture and deformity. In hand, the wrist is in slight extension. Again, that is the functional position. That is the metacarpophalangeal joint is in the 60 to 70 degrees of flexion. Wrist is in 0 to 5 degrees of extension. PIP and DIP joints are in full extension, and thumb is between the radial abduction and palmar abduction. And to prevent the shoulder abduction deformity, airplane splint can be given. Lastly, there are certain points to consider for optimization of the splint use. First one is the material thickness which is used. Use thinner materials for the finger splints and thicker for the forearm and elbow splints. Function, always consider the patient's goal and functional needs. Patient's input should always be added, whether the patient is comfortable in the orthosis, what are his preferences. Cosmesis, consider patient's age, occupation and other factors. Color, allow color choices to improve compliance, although there is not much color choices right now. Wearing schedule, tailor wearing schedule to meet the goals of the patient. If a patient is a kid, he has to go to school, or whether he is going to office, then accordingly we can change the schedule of the orthosis. As in scoliosis, the patient has to wear this orthosis on full time. Then design, then consider the goal as per the biomechanics of the involved deformity or the part of the body. Thank you.